Today, we welcome Professor Cory Cronin from Social and Public Health with What Does the Community in Community Hospital Really Mean? Cory.
Thank you very much. Hi, everyone. Thanks for having me. I think I have a sense, but so I don't bother anyone just trying to study for finals next week. If you'll just kind of raise your hand if you're kind of here for this or here for the free coffee at least, which that's what I'm here for, is the free coffee. Let me introduce myself. So, as David said, I'm Cory Cronin. I'm an assistant professor in the Department of Social and Public Health here at Ohio University, and I really like hospitals. That's what I want to talk to you about today, is hospitals, is healthcare. I have liked healthcare for a long time now. Before this job, I worked for a health system in the very northeast corner of Louisiana, a city called Monroe. I worked for a Catholic hospital that had been in that community for more than 150 years. And then after working there for about 3 years, I took a job in consulting in healthcare that really worked with physicians looking to create outpatient surgery centers. And the contrast between these two settings in healthcare, 150-year-old Catholic hospital in the community, very much central to the community, and physician practices looking at things very focused on convenience and efficiency and expediting things. It had me really, really interested in the big picture of healthcare and interested in going into healthcare policy, which is what I study today and look at and talk to students about. So I really like hospitals, I really like healthcare, and I'm hoping today to see if I can't convince someone. Who here really likes healthcare? Okay, a few hands, so maybe we can get some more hands. Who here is really confused by healthcare? Okay. Who here's been really frustrated by healthcare at some point? Okay, that's probably our most hands, so that's part of this. So what I thought we'd do, because there's never been one, B-Dubs has trivia nights, different bars have trivia nights, but none have ever been focused on what I know the most about. So I got to design tonight. So I thought we'd do a little bit of trivia, only here the trivia is going to be totally based on healthcare. So, is everybody ready to do this? This is going to be by raise of hand. I don't want just one guess. I want some guesses. So let's see where our base knowledge is, where our foundation is on healthcare, and then we'll talk a little bit about the community side. But curious, what is the salary of a hospital CEO? Give you a few minutes to think. Maybe I should have brought paper you write down. We have our first guess. $250,000, okay. It's not fun with just one guess, though, so we need some participation. Yes? $500,000. Other? 300, so going in between, just in case we're playing Price is Right rules, right? Put yourself right in between there. Let's get one more guess on the board before we reveal the answer. Yes? $4 million. So we'll put that. All right. So let's see here. Now this is, of course, I'm being general. I have to be general, but let's look at this. When we look at executive compensation, a group looked at the 82 largest health systems, and it found that 13 of these 82 paid their top leaders between $5 and $21 million. Now, this is salary, bonuses, etc. Nonprofit hospital leaders can earn 61, so the most of these organizations was between 1 and 5 million. So I think our person who guessed 4 million gets to take this point home, clearly. Okay, let's stay in this world of talking salaries that are going to make us all jealous, and this time move to a health insurance executive. What is the salary of a health insurance executive? So I'll put hospital here, and we'll go health insurance here. So what is the salary for health insurance executives? Yes, sir. 50 million. That last one kind of prepped us a little bit, maybe, to swing harder out of the gate here. So 50 million's our first trivia guess. We need more for it to be competitive. Yes. 10 million? Okay. Let's put one more guess on the board, or maybe maybe it's not a guess. 42 million, okay. Finding that nice spot in between again. That's always a good strategy. So let's look here. This is a little more nuanced that I want to talk about, but I think important for us to consider. So over here, we have Cigna. I had to choose for this data set. I had to choose a health insurance company. I couldn't just talk generally, but this Axios this website lets you pick which insurance company. So I picked Cigna, a major private insurance company. And this is by year, but you can see Cigna's chief executive earned the lowest tiers about 10 million, and our highest point was about 49 million. So you're all on the board. You're all right at some point in time. Their most recent earnings in 2016 that are reported are $22 million in their executive compensation. So for Cigna, a private health insurance company. What's maybe more interesting to me, I know these numbers are fuzzy. This is for an organization called WellCare. Has anyone heard of WellCare? Probably not. But the interesting thing is WellCare focuses exclusively on managing the Medicaid population. So Medicaid in the United States, I don't want to make any assumptions. Medicaid is our program. It is a federal state partnership. So Ohio has a Medicaid program, and Ohio contributes a lot to that budget. Gets to design the program some, but it's also contributed to by the federal government, and there are some rules we have to follow from the federal government. WellCare works with states for the Medicaid population, and their CEO salary is right around $5 million that we're seeing up here. So the health insurance program in the United States designed for lower income individuals, families, children, disabled individuals, etc. States outsource this work to private companies like WellCare, and this is what their executive makes. Okay, everyone's with me. We're getting into the flow of trivia, right? This is working okay, so let's keep going. We're gonna move away from, again, maybe a focus on this. This one, I have some hope for us. I can see in the room that there are some people who I maybe wrongly would expect to have no idea, but there are some people in the room who maybe I think might have an idea here. How much, on average, does a United States family pay for their health insurance premium? Now, I want to be clear, premium is the monthly membership cost that you pay in health insurance. So if you know very, very little bit about health insurance, it's like what you pay to be able to watch Netflix. Every month you got to pay and that price keeps going up for Netflix too. But this is on the health insurance plan. So just to maintain your health insurance, to not be kicked off the plan, families owe a monthly subscription to health insurance. What is the average monthly premium families in the United States pay for health insurance? $1,200. So $1,200. I'll put that on the board. Any other guesses? Yes. $400? Let's get at least one more guess on the board. $1,500? Bit of a different strategy there, going on the high end. All right. Is there anyone in the audience who really, really feels like they know this one, but maybe they're being shy to say it? Anyone? Okay. Well, that's okay. So let's look. So we've got, again, a graph here. Orange is the United States, yellow is Ohio, and we've got 3 different points. Most people in the United States, the largest group of people in the United States, get health insurance with assistance from their employer. So that's about 49% of us in America. get our health insurance as a benefit of our job or with our employer helping us pay some of it. And that's what this graph is focused on. About 14% of people in the United States get their health insurance from the Medicare program, the federal program that is for anyone 65 and older who is a US citizen. About 20% are on Medicaid, which I mentioned earlier, our insurance for lower income adults. And then we've got a very small percent of people on different types of health insurance, various health insurances. But let's get back to our trivia question to see who's right here. So we are looking at the circle for the employee contribution. And this is, I think I asked the question before in a month basis that I shouldn't have. It'll require me to do math. This is an annual basis. In 2018, the average American family spent about $5,000 on health insurance premiums. So somebody quick help me with that, divided by 12 months. $400. So we got a good winner here. Now let's stay on this though, not just to get the trivia question right. Let's look at how expensive health insurance is in the United States, because we need to bring in our employer too, who is helping us. Many jobs, the split here is that your employer is actually willing to pay 70 or 80% of your health insurance costs for you as a benefit, and the employee is only left with a small 20 to 30% of those costs. So the average family in 2018 spent, before you use any health care, this is just the subscription cost to health insurance, to be on a health insurance plan, is about $19,000. The average American family buys a new Volkswagen, or at least the equivalent of it, the cost. If we saw a family on our block buying a brand new car every year and not even trading in the old car, they're just piling up in our driveway because we're spending $19,000 a year on cars, I think we'd wonder about the sanity of that family to some extent. We're spending the amount of money of a car, I just think that's worth thinking about, of a new car on health insurance each year. Now, health is important, right? I'm not saying we shouldn't spend money on it. Okay, again, we're just playing trivia here though. So, move to a little different perspective of healthcare costs. We've talked about subscriptions for health insurance. We've talked about employment and what people make in healthcare. What about what does healthcare charge? What's the average cost of a colonoscopy? So, cost or price or actual price or list price, we don't know in healthcare, do we, what we mean when we say cost, which is a good point. So I'm going to leave it as vague as I said it. What is the cost? What does the hospital charge somebody who walks in off the street? We don't know their insurance. So list price is probably my most technical term here. What is the list price of a colonoscopy for a hospital in the United States? Yes, $1,000. We'll start there. Yes. Say 3,000, and then I heard going to 10. So 3 to 10. Anyone else want to take a guess? We're going to the lightning round after this. So if you feel you haven't really participated, you want to get involved, now's your chance. No, you can participate in the lightning round. Okay. So let's look at this. We've got a couple things on this graph too, again, just where I'm getting my data from, but we're going to start over here. So between these two is our right answer that a colonoscopy costs in the United States about $1,000. Can see in Switzerland, not quite that much. Interesting to look at other things here. A hip replacement in the United States is about $40,000. It's the average charge of a hospital. For Spain, you're getting quite a discount. And then let's look at a prescription drug, because we love to talk about the cost of prescription drugs in the United States. Big topic right now. Lipitor in the US, about $124. New Zealand, you'd be paying $6 for that prescription. So healthcare costs, kind of a mess in a lot of ways. Oh, I thought we were moving to lightning. I've got one other that we're going to cover. I like this one. I like to ask just average people this one, because again, this is where you realize that because you've been interested in healthcare since you were, I don't know, I'd say 23, and you read a lot of books on it and stuff. You're walk around thinking everyone knows these things. So I think this is fun. This is fun for me to be able to put together trivia based on, again, the thing I know well. It's not football or musicals or Disney, though I'd be pretty good at Disney, I think. put it together on healthcare. How many hospitals are in the United States? This is probably my favorite question of this set of trivia. How many hospitals are in the United States? 20,000 hospitals. How many hospitals in the United States? If we only have one, he wins automatically as closest. Yes? 15,000. 40,000. Doubling our highest. Anyone else want a chance to guess the number of hospitals? 41,000. All right. All right, before I show the answer, because like I said, this is maybe my favorite one. I like this. Could you explain your thought process in coming up? You came up with the 20,000, I believe, right? Number?
Well, I don't know. I thought about just the capacity to care for people.
Okay.
And I'd like to think that, we have we in the United States, we do have a pretty large capacity to provide health care for people.
Mm-hmm.
So I was just thinking with the populations and like, I don't know, 20,000 just seemed like a ballpark kind of.
Okay. All right. So let's look at this. Like I said, this is one of my favorites. So I've got a bunch of different stats up here. They'll come in one at a time. Our important one, though, is the total number of hospitals in the U.S. We have 6,000 hospitals. Don't feel bad. Everyone guesses in the tens of thousands. 30,000 is my most popular when I ask people this, when I'm curious. Most people say 30,000 hospitals. That sounds right to people. I'm not sure why. I'd love to learn more about that someday. Why people think the United States 30,000 is about the right number of hospitals. We have 6,000 hospitals. And even with this 6,000 number, this is a pretty broad definition of hospital. To meet this definition, a hospital has to have at least 6 beds. That's it. Only 6 beds, and you're a hospital, according to the American Hospital Association, who gives these numbers. So we have 6,000 hospitals. We're up a little bit. Our hospitals, we're opening new hospitals, which is interesting because we're also closing hospitals. Rural hospitals right now are closing at an alarming rate, but it means we're opening more hospitals as other hospitals are closing. So it's a shaky ground. Now, my topic tonight's on community hospitals. What we would consider a community hospital, you can picture Ohio Health of Blenheim, for example, for this. That's a traditional view of a community hospital. Those are about 5,000. We have about 5,000 community general for anybody, not specialty, but general hospitals. A few more numbers for you because, again, I like this stuff. We have about 2,000 rural hospitals. Like I said, this number is actually down from the previous 3 years. Our hospitals in a system, this is a big trend, meaning that the hospital isn't standalone, it's not independent, there is at least more than one, and often we see large networks like Ohio Health, here in Ohio, or the Cleveland Clinic. The majority of hospitals today are in a system, and this has changed quickly. And when I say quickly, in the last 15 years, this crossed over to being the majority of US hospitals are now part of a hospital system or a multi-hospital chain, however you want to look at it. Our total staffed beds, so just for a big number, it's easier to focus per person. In the US, we have about 3 beds for every American, compared to, 3 Americans for every hospital bed, compared to 2.6 in Canada and the UK. So we're really not that far off other countries that we often compare ourselves to. Total admissions, and then for a really, really big number in the trillions, how much money do hospitals spend in a year? $1 trillion. So these are our hospitals. All right. Who owns a hospital? And this isn't a right or wrong answer. This is, in fact, there are multiple correct answers to this, but who owns the US hospitals? Doctors? Okay. Well, I'm not going to write because there are multiple right answers, so we'll talk about that. Yes? The government? Any others? Religious organizations? Corporations? All right, all of these are right. All of these are right, but you have in fact missed the biggest owner of hospitals, or the most common's probably the right word. Do you want to take a guess? You're thinking?
Communities.
Communities. Can a community own something? We're not very good at sharing. We'll see. So when we look at our hospital population, private nonprofit, you might say community, religious organizations would fall into this category most often too. This is the majority of our US hospitals, and that's going to be important to what I'm going to talk about for a little bit to you tonight about. Private nonprofit hospitals, about 60% of our hospitals are private nonprofit. Many of these today at one time were public hospitals, government hospitals, and a nonprofit purchased them. But these are what we would often consider to be owned by the community. Public hospitals only make up about 20%. We don't have a lot of public hospitals in the United States that would be government owned or operated in some way. Public hospitals, to meet this definition, typically some of the money they use to operate would come directly from taxes of county residents, for example. And then we do have private or for-profit or investor-owned. We have a lot of languages for this. Hospitals in the United States. Somebody who said doctors, that was our first guest, somebody shouted out doctors. When a doctor or a group of doctors own hospitals, they're most likely, usually this category, that they are private for-profit. These hospitals, unlike the other two on the board, and sorry, I'll just bring in my graphic. These hospitals, they often have shareholders or investors, and when the hospital does well, when they have more revenue than cost, they are allowed to write checks to individuals who have invested, who have given them money, who are owners of them. So a question is, we have private for-profit, we have nonprofit. Does nonprofit mean no profit? Okay. See some shaking heads no, which is good, you're a smart audience. No, that's a misconception. Nonprofit hospitals, we don't call it profit, we call it revenue. What is key, the key difference between these two is private nonprofit hospitals, by law, are not allowed to benefit individuals from them doing well. They are supposed to invest that money that they earn on top of costs either back into their organization or into the community in some way. So that takes us, that point brings us to our lightning round, because I'm afraid I'm giving away a little bit too much here. So should companies, not people, should companies be taxed to support their local communities or beyond, to support the state of Ohio, to support the country? Should companies be taxed? Should Walmart pay taxes here in Athens? And well, let me ask that question first. Who thinks Walmart should pay taxes to the city of Athens? Okay, what's a good justification for why Walmart should pay taxes to the city of Athens? Why should they do that?
Athens has the university, and it brings in all the people who go and shop.
Okay, so the community supports them.
Customers, which supports the business.
Okay. Any other reason someone like Walmart, it doesn't have to be Walmart, someone like Walmart should pay taxes?
Fire protection.
So they need services, right? Now, hopefully not. Hopefully there's not a fire or an emergency, but they may need services that the city provides. That's costly to the city. That comes out of taxpayer dollars. People don't just appear in Walmart's parking lot. They drive on the roads to get there. So they do some wear and tear on our roads. We need police, etc. So all these ideas, I think you guys are thinking along the right lines. Most people don't have a problem with companies paying taxes to their communities, especially when we think locally often. Hospitals, though, this is the topic I have, is the community and community hospital. We call hospitals community hospitals. Do they need to do anything more to get that title of community? If they're owned by the community, which was brought up earlier, do they have any additional responsibilities, or can they just focus on scheduling patients, billing insurance, whether it's government or private? Do we think hospitals are held to a higher standard? Do they have to do anything more? Yes. So they have to stick to zoning codes. We can't, give me an example of what? We can't put a doctor's office in my neighborhood. Yep, that's true. What else? But we have a public health department. So should they just pay taxes to support that? Would be a question. I'm not trying to attack the audience. I'm just asking a question back. So this is our lightning round. I will move quick, and this is really a lot of what we're going to talk about. Yes, nonprofit hospitals in the United States for a long time, and I'm going to give you a little bit of the history. I'm going to give it to you quickly. I'm moving slower tonight than I thought I would, but I think that's okay. Hopefully good conversation. Nonprofit hospitals don't pay taxes. A lot of things don't pay taxes, though. Churches don't pay taxes, for example. But it's interesting in the United States that we decided a long time ago that nonprofit hospitals won't pay taxes, but they have to continue to prove to the federal government they deserve that benefit, that exemption, so they are required to report something called community benefit. And that's what I study. That's what I'm really interested in, is hospital community benefit. And it's a legal definition, an IRS term, and we'll get to it. What could hospitals do? I'll count education here, doing education for the public. What do you think would be community benefit that hospitals could do? What could they do to benefit their communities? Yes, Rex.
They could go out into the community, like community vans.
So they could offer services that maybe typically you have to have insurance or money to pay for, and they could give those services away. Any other ideas? Now, maybe I should have asked early, who here is connected to a hospital or has a family? I won't. I'll risk it. Let's just be very, very theoretical here. I find my students who are interested in healthcare, like I'm interested in healthcare, sometimes, every now and then, it's a great moment as a teacher to get like an aha look from a student. I feel like I get this sometimes with this. So we're saying hospitals benefit their community. Let's be very theoretical. Let's say hospitals give away health services that you might have to pay for. They're educating people so well, and they are now operating in the healthiest community in the United States. Do you think that makes the hospital happy? We have to understand the way health policy is set up today, the way reimbursement for healthcare providers, including hospitals, are today, is they actually financially do better if people are sick, because those are the people who use their services. If we take an extreme theoretical, a hospital operating in a perfectly healthy community would close because no one would need their services.
Don't the insurances have some programs are to keep people healthy, so they have preventive? They help you with preventive care, and some others are there so that they help you when you get sick.
So if we brought into healthcare providers, there is primary care, preventive care that physicians offer, but that's not a hospital level service. Does that make sense? I saw another hand, yes.
It seems like there are many hospitals that do programs for particular at-risk populations where it's that they are not seeking health care, and by being brought in to participate in a program, they might actually then get the health care that they need.
Completely agree. And let me tell you, what I'm being critical of with this idea is not even hospitals themselves, but the way we reimburse. The idea that in the United States, what we call healthcare, we often mean sick care. We are focused on treating people after something goes wrong, because we don't know how to pay when somebody's healthy. We don't know. Now, there are reimbursement models that's probably for a longer, a deeper conversation, that there are some really interesting experiments going on out there in different states about how we might actually incentivize hospitals to actually keep people outside of the hospital. To what you're talking about, a couple of things. A cynical, a bad view of this is I have seen hospitals who will offer the screening for cancer for free. Not in hopes, that sounds too negative, they're not villains. Thinking maybe if there is a cancer diagnosis made from that, they will have a new patient that they can bill for services. So that's a bad view. Now, another good view is there are at-risk, vulnerable, disadvantaged populations. We could say all kinds of phrases that the hospital knows they're going to use their emergency room for services, and that's not the appropriate place, that's not a cost-effective place to treat them, it's not a quality healthcare place to treat them. So they'd rather set up a community program to treat them at the right level of care. Maybe that's a primary care clinic on a Saturday. So we'll talk some about what hospitals do. Okay. What should I'm going to skip this one. What should they do? I think we've kind of talked about that here too. So, is what hospitals do enough? Is one of the questions tonight. And let me check time. Okay, so a little bit different here. I need 4 volunteers. And I was nervous coming into this. It's hard to get people to volunteer for stuff. You're not going to have to do a dance or sing a song. You're just going to have to think and write one number. That's it. That's all I'm going to ask from you. So I need 4 people who are willing just to come up here, hear me say something to them, and write a number down. Don't rush the stage. I've got 1 volunteer. I've got 2 volunteers coming up. You will be a team, so you all come over here for me. I need 2 more volunteers for this to work. All right, I've got 2 people coming up. Great, great. And important, I need to tell a secret, so I don't know how to turn my microphone off. So whoever controls my microphone, I need a minute to tell a secret. All right, so you guys stand up. All right, do we have yours? Okay. Thank you. Are you guys close? Are you there? Okay, you can in fact sit down. I don't need you up for I may call on you. So you all are sitting close to each other, right? All right. I can be turned. Am I on? Mic-wise? Okay. So I never know quite how this will work out, but it always works out, so I should never be afraid. This is an important policy lesson, and hopefully with our conversation up to now, we're all in this room feeling pretty good that community hospitals should do things to benefit their communities. We expect that of them, maybe even, we would say, but we'll talk about that more. And again, I haven't given you a lot of the boring slides with the history and stuff. If we have time, I'll get to that. What I did in this activity and what I like to do, each of these groups were community hospitals who did pretty well last year. They had $100,000. Now, we could add as many zeros here as we want to be practical and real healthcare, but we're trying to keep it manageable. They had $100,000 that they brought in more than what they spent last year. So they've got this extra $100,000. Well, there's nothing wrong with your answer, maybe. One group's stingy. What I asked each group to do was to plan their community benefits for the next year, and how much of this $100,000 are they going to spend on community benefits? And my group over here, if you'll raise your hands, I think we have the Grinches, right? Only $20,000. This group's going to do $70,000. What's going on? You don't care about your... No. So I did something that is a policy lesson that is very interesting. We're asking the question, do hospitals do enough? I want to tell you, hospitals live under the fear of not doing enough. Congress has vocally written papers and had hearings and scrutinized nonprofit hospitals if they do enough. This group existed very much in most of the United States, where all I said is, how much are you going to plan on your community benefit? You can see their number is $70,000 of this $100,000 they're going to do in community benefits. The one question I do have for you, what are you going to do with the rest? Save it for a rainy day? Save it for, okay, I just think that's an interesting question. What are hospitals going to do with the rest? Why not spend it all? No one in me ever doing this has spent it all on community benefit, which is interesting. So what are you going to do? My group over here, what I told them different, in fact, was that by law, they had to spend 5% of their community benefit or their money on community benefit, or they'd get in a lot of trouble. This actually happened in the real world. Texas did not think their hospitals were doing enough community benefit. They had some really low performers they wanted to bring up. So they put a law in the state that hospital had to spend 4% of their operating expenses on hospital community benefit. It backfired on them. Over the next 5 years, the total community benefit spending by hospitals in the state of Texas went way down. Why would that happen? They put a law saying you have to spend this much. Why would that happen? So they may have brought their poor performers up, but what they did more was give some people who were doing a lot, because they never know when they're doing enough, they gave them a target and they came down to that target, and that coming down to the target was more effective. I don't love that policy lesson. I like the idea that maybe hospitals would know what to expect when they've done enough, not feel like they're running and the finish line keeps moving on them. But I also don't like the idea that once you put a goal, people will maybe cut off their spending after they hit it. So it's an interesting question. Do hospitals do enough? How do we get them to do enough? Let me just throw out to the audience, and watching time, because I do want to leave time for questions, throw out to the audience, what would be enough? What is enough community benefit? So I've given you this. I know you don't have a lot of information about hospitals. Don't pay taxes, and the nonprofit hospitals don't pay taxes in the United States. And the government, giving them that favor, asks in return that they submit to the IRS every year what they did to benefit the community financially meaning how much money they spent to benefit the community. What would be enough? How could we measure that? How could we define enough? Yes? So maybe we go back to one of my slides earlier. I'm glad that stuck in the brain. I was trying to frame this conversation. Maybe they have to spend what they compensate their leadership. Could be a measure. Any other ideas of what is enough? How we should define enough? When have they given enough away? You've got an idea, I can tell. Mm-hmm. Okay, so maybe it's a model that looks at, like did they have 100,000 at the end of the year, and maybe they spend some or all of from having outlandish charges. Yes?
More than the amount of taxes that they would have had to have paid if they were not.
Elect her to Congress. This is what Congress keeps saying, is they want to measure it in the tax benefit they get, and they want us to zero that out. What do hospitals save by not paying taxes? Well, that's what they should spend in this. Not a bad idea, though I'll tell you, because I'm on stage and I get to tell you this, I don't love that idea. What if instead, let me just throw this out and then I'll move on, because I don't want to be the one to come up with the smart idea on the spot. I've never thought of this before, I promise you. I'm just coming up with it right now, and you could, no. What if they moved the needle on a health outcome instead of we care what money they spend at all? What if we had fewer kids in the ER with asthma complications, and that's how they prove they're doing community benefit? Is an idea that I sometimes, studying this and looking at it every day and data sets, et cetera, get tired of the dollars being what matters when we're talking about community benefit. Maybe we should measure community benefit in a different way than the money spent. Because the truth is, and I don't know if I'll get to these slides, so I'll tell you now, the truth is we've known for a long time in healthcare that some of the most effective things if we're consistent but patient with them, some of the most effective things in healthcare are very, very cheap to do, in fact. The expensive things have immediate results, but we can do very effective things. All right, I just want to say, and I'm going to move kind of quickly now because I do want to leave time for you to ask me questions at the end in general. One thing that's complicating this is that nonprofit hospitals, so I'm only going to talk about nonprofit hospitals from here on out because they are the only ones who have these expectations. Nonprofit hospitals, and not all of them, I want to be very, very clear, not all of them, but they're being portrayed very negatively in the media right now, whether it's New York, well, I'll put the articles up here, whether it's the Atlantic or the New York Times, Kaiser Health News is a major healthcare outlet, Washington Post. Hospitals, nonprofit hospitals have gotten very aggressive in how they collect bills from patients who haven't paid their bills. And this complicates the story of community benefit. A lot of people are asking if nonprofit hospitals should, and the truth is, they didn't used to, not that they didn't used to have debt owed to them, but things like putting liens on people's houses or garnishing people's wages or selling people's debt to other collectors, these are all relatively new and, to me, alarming practices of nonprofit hospitals in the United States. I'm sure there's a counterpoint to this, and there could be a discussion around their business operations, and they, of course, need to stay open to provide care to anyone in their community, so maybe these things are necessary, but I think there needs to be a deeper conversation about that. So, all right. So some of the ideas, and I like this illustration too, in healthcare, and there's no test, so you don't need to take notes on this. I'll put both of these up. In healthcare, in Ohio, it's estimated 96% of the money we spend on healthcare would be a downstream approach to healthcare, a clinical treatment approach to healthcare. I'm sorry, I said 96, I mean 94. 6% of what we spend on healthcare in Ohio would be classified as an upstream, or trying to get at the root causes of health. Now, I like this upstream, downstream language, and maybe I'm leading too hard into this, and so I want you to get it the way I get it. So let's pretend we're in August, not in December. Let's pretend we're on the bank of the Hocking River and not in a coffee shop because it's nice and it's warm out and we want to enjoy nature. And we're having the same talk out there, and one of you notices that a baby's coming down the river. What do? Just by itself, unsupervised, just screaming. Of course, it's terrified. It doesn't know how to swim, and it's coming down the river. What do? So jump in the water. Okay, so we got that baby. Woo. We can have our conversation about important things like hospitals again. Wait, another baby's coming down the river. What are we going to do? Another baby's coming down the river. What are we going to do? When are we going to go up the bank of the river and see who's throwing babies in? In healthcare, we're not seeing what are causing the things, we're treating the things after they've been caused. That's the idea of upstream, downstream. It's bigger than healthcare, but it's, I think, a powerful illustration in healthcare. We're also interested in healthcare today of thinking about the social determinants of health, so not just viruses and other biological things, but housing is a huge healthcare topic. We don't think of it that way, but our houses can either promote good health in us or they can make us really sick. They can either help us do the things we need to do or be major hindrances to the things we need to do. So more social determinants of health. And I'll say people who are interested in healthcare, no matter what part they work in, I haven't yet found somebody who's not interested in improving the idea of health equity, which health equity is the idea that we all have equal opportunity to being our healthiest selves, that we want to reduce the structural, the systematic, the barriers that advantage some people in health and disadvantage other people in health. We want to create equal opportunity to health. I'm going to skip this one, in fact. How do we know health is social? Because your zip code is actually a huge predictor of your health. And it shouldn't be that way. And I'm probably not the first person to tell you this. What about your zip code makes you healthy or not healthy? What about your zip code might make you healthy or not healthy? Yes?
Access to fresh food.
So access to food. I thought you were going to go where I wanted you to go so that I could tell you you're wrong. No. Maybe access to high-quality healthcare. Well, what we have here is Cleveland, Ohio. Cleveland is known for a lot of things. A lot of people in this room probably have Cleveland connections, and I lived there myself for 5 years. So I have Cleveland connections. This is not one of the great things Cleveland is known for. Cleveland is known for having the shortest geographic distance that has the biggest difference in life expectancy. So right here in the Huff neighborhood, life expectancy is 70 years. This is right outside of the Cleveland Clinic stores. One of the best healthcare systems in the world, one of the top quality healthcare experiences you can have if you can get in the doors. Huff is right outside of the Cleveland Clinic stores. Life expectancy is 70 years. Beechwood is about 12 miles away, and there you get more than a decade of life. You get to enjoy an additional 12 years of life on average. Average life expectancy is 82. This is the shortest geographic distance traveled with the greatest distance, or greatest increase in life expectancy. Nothing about our zip code should affect our health as far as it can't make us sick. But it does because of access to healthy food or housing or violent crime and we could go on and on about what about place. But this tells me that health is certainly social. It's very, very social. It's not just about those physical things that we often talk about. All right, so we brought up the idea of hospitals maybe spending as much as they get in tax exemption. The value of that tax exemption, what the local, state, and federal governments are foregoing by not charging nonprofit hospitals taxes, is about $25 billion. That's a big number. Now, maybe not when we talked about hospitals spending over $1 trillion, though, every single year. This is a big number, but not even as big as what hospitals spend on other things. So I want to get to this, and then I'll probably leave open room for questions. In this work I do, and looking at how hospitals benefit their communities, the IRS has allowed for them to do different things and call it all community benefit. So they can do research, that's community benefit. So like the Cleveland Clinic does a lot of research, and they get to classify that to the IRS as their community benefits. They get to do community health improvements, like the screenings or the mobile clinics we kind of talked about. They get to do charity care. When I look at this pie graph, this was done in 2015, looking at where hospitals spent their community benefit dollars. So we've been talking tonight, do hospitals do enough? Is it enough? I hope I've introduced the idea of upstream versus downstream approaches. The vast majority of what hospitals do and call community benefit is treatment. They just don't charge for it. So charity care is when somebody comes to an emergency room without health insurance, and the hospital decides rather than aggressively trying to collect the bill, they'll just put that person's visit into their charity care category. 25% of what they call community benefit is charity care. 45% of what they call community benefit, they're claiming when a government payer like Medicaid pays that they're not getting their full bill paid, and so they're counting losses on Medicaid as community benefit. So well over 60% of what hospitals are calling community benefit isn't really about the community, it's about the individual. The individual and it's very important when someone goes to the ER that they're treated. I'm not at all saying that. I'm just saying if we're going to look at community benefit, again, my idea, what I would like to see, then moved on, is maybe we look at things available to the community. Maybe we look at things that are more about health than about treatment. So even in this concept of community benefit, when you think about community hospitals, hospitals seem to be very narrowly staying in a provide treatment form. So again, I had more for you, but it's boring history slides. I think you'd rather me take questions probably, so we can talk about what you all want to talk about.
So let's thank Cory and then have questions.
Yes. What are some of the factors that influence healthcare availability? A very, very good question. So one of my pet peeves in US healthcare, I've already told you we say healthcare means sick care. That's one of my pet peeves. One of my pet peeves is we often talk about access to health care, and what we actually mean is access to health insurance. So our biggest one, or at least the one our government is most focused on, is that somebody has health insurance, whether that's a private health insurance plan, maybe it's affordable for them, maybe it's not, or a public program that gives more people access to health insurance, like Medicaid expansion's done, giving millions of Americans access to health insurance before they did. But a very, very good question, because a lot of people stop there. They say, okay, someone has health insurance who didn't have it before, they're set, my job's done, we can walk away. I'm doing a study right now in Athens and 11 other counties in Ohio looking at transportation as a barrier for healthcare. And I don't have published results out of this yet, but early on, I'll tell you, only about 12% of my sample, when asked, is transportation an issue for you getting the healthcare you need? Only about 12% said transportation was their issue. Later in the survey, I asked a question of, have you missed an appointment in the last 12 months because you didn't have a ride? And that is 25% of people have. So double those who recognize transportation as an issue completely missed a doctor's appointment or treatment because of a ride. So transportation's a big one, especially in counties like Athens. Even if you have health insurance, there are copays and deductibles, and there's wonderful reporting out there right now. Sarah Cliff is a journalist to follow. She's following people's medical bills. She's asked Americans to send her. She's received 500 or so medical bills from people because she's asking the question from a journalist perspective, why in the United States can you pay all this money we talked about for health insurance and still not be able to afford health care? But that's the reality for many Americans today. So even if you have health insurance, you're going to receive bills afterwards. Does that satisfy? I'm sure we could talk more. Okay, yeah. Education's a big one too. Like, how much do you know about when and how you should be using health services? Other questions? Yes? What is the main reason hospital CEOs earn so much money? Let me give you the industry answer because I spent some time in the industry, and I believe in this somewhat. If we've got cell phone companies and manufacturers and video games, I don't know, social media networks, paying leaders in the millions of dollars and healthcare paid a good but not that salary, all of the talent would go to other industries, and healthcare is incredibly challenging and complex, and do we want to lose our talent? I think there's some truth to that. I think we've all seen very important roles in our society. Both my parents were teachers or caseworkers or social workers. Very important roles in society that are undervalued in compensation, and I think it can be a struggle to staff them appropriately because some people will say, I can't do it. I can't support my family for what you're offering to pay for this stressful, hard job. My counter to that a little bit will be, I have known people who have gone into healthcare because they see big salaries and big dollars, and they don't stay in healthcare because I believe you don't put yourself through the, and this isn't to, there's a very human, emotional side of healthcare. I want to impress on my students how often they're going to meet people on the very worst day of their life if they work in healthcare, whether that's just a bump in the elevator of the hospital they work for. They're going to just be going to lunch, and a family member just got horrible news who's in that cafeteria. So I think healthcare is somewhat self-selecting, too, that you have to care. So I wonder, do we have to pay them quite so? I don't know. But people will say we would have a brain drain or talent drain to other industries if we didn't offer competitive compensation like this. That is an excellent question. So, I'm sorry. Yes, I will. Does a hospital have having a religious affiliation influence their maybe orientation towards the community? It does. It does. I can tell you in that. So, I download the IRS forms that are publicly available to see how much hospitals spend on community benefit, and consistently, if a hospital is religious, now I don't know what Catholic hospitals, there are big Catholic health systems in the United States, there are Methodist health systems. I don't know those details, but to put a variable in, is the hospital have a religious affiliation or not, the ones who do are statistically significant is the language, likely to spend more. So I'll give you a more real-world example, though, than talking about things like statistically significant. The Catholic health system that I worked for had a vice president of mission, and I think it was very important that she was at the table. And in fact, my interest in this kind of work came from working with Yvonne, working with her, our vice president of mission. She fought very, very hard to get a school-based health clinic in our town that was not going to generate revenue or be profitable for our hospital. It was going to lose money, in fact, especially right after it was opened. And she kept asking other leaders to support her in this, asking our board of trustees to support her, and she kept getting no as an answer. And she brought me on because I knew numbers. And she's like, we've got to convince them somehow. Tell me how many kids from this part of our town where this school-based health clinic would be went to the ER when, if they had appropriate primary care, they probably wouldn't have gone to the ER. So we call this a preventable hospitalization. And I ran those numbers, and she promised the board, we will reduce this by half in the first year and down to a quarter the second year this is open. And the board got on board. The board was happy to financially support them. But yeah, so I saw someone in that role of VP of mission. I'll tell you, not every hospital has a VP of mission. I think sometimes that comes with an additional religious component. Used to be almost every hospital was religious. So in our history of hospitals, that was who was willing to fund them and build them, type of thing. So,
One last question I would
okay.
I have a question that was asked via Twitter.
Okay.
They wanted to know whether or not healthcare that you've been talking about has been affected by Obamacare.
Has healthcare been affected by Obamacare? So yes, it has been affected in that, and this is part of the Affordable Care. Let me just say, another pet peeve of mine in healthcare is people want to treat the Affordable Care Act as whatever they see it as and as one thing. So I'll just preface to say the Affordable Care Act made hundreds of changes to our healthcare system. It's a very nuanced, detailed policy. One of those that directly relates to this that I'm very, very interested in is after the passage of the Affordable Care Act, hospitals have to do a community health needs assessment every 3 years. So they have to, the way the law is written, now oversight enforcement's its own thing, they have to involve the voice of the community in this. So they have to have roundtables and focus groups. And the community has to tell them what their health needs are. From this report that they then write up from the community, and they have to make it available on their website, so you can go to any hospital you can think of and search Community Health Needs Assessment, and you should be able to download their report. They have to create an implementation plan. So they have to pick 3 to 5 of these things the community said were important, and they need to write a report saying how they can impact that, how they can do better at that need. Then, of course, they have to submit data. No, it stops there. They assess their community, they write a plan of how they'll improve it. We are not yet to the point where they have to submit data that they've actually done anything. I can be critical of this process. I won't be too critical. I've been critical of a lot of things nonprofits do. I think this is a move in the right direction, that they at least need to hear from their community what they feel their needs are. So let me ask you, what do you think is one of the most common? So me and a colleague, Berkeley Franz, in the Heritage College of Medicine here, we've spent the last year working with different students funded through different streams to download 20% of hospitals' community health needs assessments, because these are just PDFs, so we can't just like open a spreadsheet and have all the data in front of us. It's very labor intensive to get these. So we've had students download 20% of US hospitals, so we have about 600 hospitals health needs assessments, and we've been looking at, things like, are they different in different parts of the country, what people's needs are. It's surprisingly consistent. What do you think are showing up on these health needs assessments? What do you think, not hospitals, what do you think communities would tell hospitals the need of their community is? So access is a big one. Education's one of our fringe ones maybe, but access is a big one, though not one of the top. I'm surprised I wanted to say it's not a big one, but Athens, for example, jobs is what people are telling hospitals they need. And I love that, because that makes hospital leaders think different about health when it's, I need jobs, I need an income. Substance use is one of the biggest. Like I'm quoting this from memory. 96% of the hospitals we looked at said substance use came up in the top 3 needs in their community. Interesting. My last shot at hospitals, I guess, tonight. I love hospitals, I do. Very few of them say they'll address that need. They say, that's not our job, that's not us. And so rather than write an implementation plan for addiction and substance use, a lot of them write the reason why they're not going to be involved in that. Some of them do a very good job. Some of them write about how they don't really know that area, but they're going to partner over here with this group, or they're going to invest in this community fund that can do something about it. But a lot of them say, not us, not our job, and they go to a chronic disease like asthma that they think they can address. Yes? Very interesting. Very interesting. Some do, and I will actually, I've been talking about nonprofits in general, and I didn't want to make this local. I will tell you that Ohio Health Oblenis actually very much took an approach like you are talking about, and I know they've provided medical staff training on the topic and wider staff training. So not wide-ranging, these are very general and trends, but the average nonprofit hospital in the US doesn't feel like that is something they should address. And I think that mindset can be dangerous, especially when you don't even consider, if you can't address it, can you help somebody who can address it? When communities are saying this is what we need.
Okay, we've reached 6 o'clock, and I think it's now time to give Cory our final thanks for the presentation.
Thank you all for coming out.